Hello everyone, myself Ruchi Patel, working as assistant professor at LJ College of Physiotherapy. Today I am going to take second year as well as third year topic that is related to the ANFIL. So let's start with the presentation. As we all know, ANFIL is nothing but the feeling which the therapist will feel when the therapist will move the part passively, and that feeling will be felt at the end range of motion. The end field are two types, normal and abnormal. So let's start with the normal end field presentation. So when assessing the passive movement, the examiner should apply the overpressure at the end range of motion to determine the quality of end field, or we can say the sensation that the examiner will feels in the joint and when it reaches to the end part of the motion. So this care must be taken by the therapist while assessing the infant, because overpressure should not be given as it can increase the symptoms of the patient. So while assessing the patient, the therapist should check for the other the condition of the patient, as well as uh, while performing the and or while checking the end, just prior to that ask the patient to perform the motion. Okay, so if however the patient has severe pain at the end range of motion, the end field should only be tested with the extreme care. So, in the maximum cases, if the patient is having severe pain, then patient will not allow us to reach at the end part of the range. As a result, will not be able to recognize the actual end field of that particular joint. So, the proper evaluation of the end field can help the examiner to assess the type of pathology which is present, to determine a prognosis for the condition and learn the severity of the stage of problem. So while assessing the ANFIL, will get to know whether the patient is having the severe issues, or the patient is getting or patient is recovering, or the condition is becoming worst. So, by determining if the pain or restriction is the main problem, then the examiner can determine if a more gentle treatment should be given or a more vigorous treatment should be given. So, based on the end, we can decide whether the vigorous physiotherapy is required or just gentle physiotherapy is required for that particular joint. So this enfill is the sensation that the examiner experiences at the end part of the range. So intra-rated reliability tends to be a good, whereas inter-rater reliability is poor. So if, however, the patient has severe pain at the end range, and the field should only be tested with the proper care, otherwise it can make the condition of the patient more worse. So Syriacs has a divided this anfield, that is in the case of normal anfield, mainly into the three types, that is soft, firm and hard. So soft, that is structure, that is the soft tissue approximation. That examples for this soft anfield are the elbow flexion and knee flexion, whereas the firm anfield, that is the muscular stretch, capsular stretch, or ligament stretch. So there are the three types of structures which can include it in the case of firm and fill. So example, like for the muscular stretch, we can say for the ankle dorsiflexion. Whenever we'll do or whenever we'll perform the ankle dorsiflexion of the patient at the end range, we can feel that stretch type of fill. Whereas capsular stretch, which we can feel during the shoulder lateral rotation. Then third, that is the normal third end fill. It is the bone to bone end fill. And this type of bone to bone end fill we can get in the elbow extension. So after doing this elbow extension till the end range, we can feel that further movement which is restricted just by uh, the bone, the articulating surfaces are coming in the contact with each other and making the joint in the locked position. So we have abnormal end fill. So abnormal end fill we can divide into the early muscle spasm, late muscle spasm. Then we have spasticity, we have hard capsular end fill, we have bone to bone abnormal end fill, empty end fill, and springy block type of end fill. So this first we'll see about the muscle spasm or muscular spasm. So this end fill, which is uh, provoked by the movement with a sudden dramatic arrest of the movement, often accompanied by the pain. So this movement will be painful, and the patient will have a complaint like he had a history of severe jerky sudden motion. This infill is a sudden and hard type of. And the early muscle spasm, which is mainly seen in the acute cases, or we can say which is associated with the inflammatory conditions. Whereas the late muscle spasm that occurs at near the end range of the muscle, and it is usually caused by the instability and the resulting irritability caused by the movement. So the example of the muscle spasm occurring during the apprehension test for the anterior dislocation of the shoulder. So both type of muscle spasm are the result of the subconscious effort of the body to protect the injured joint or the structure. So it's a protective mechanism of the body. Whenever the injuries is occurring on the particular joint, our muscles will get automatically in the tighten position. Okay, so their occurrence may be related to how quickly the examiner does the motion. Next, we have that is the spasticity. As we all know, spasticity, it is related to the upper motor neuron region, and it's a hypertonicity that offers the increased resistance to stretch, involving primarily the flexors in the upper limb and extensors in the lower extremity, and it is maybe associated with the muscle weakness. Then we have capsular enfill. That is the abnormal capsular enfill. So it's a hard capsular in which the enfill has a thicker stretching quality. The hard capsular enfill is seen in the more chronic conditions or the conditions where in the full blown capsular pattern will be there. The soft capsular, which is the similar to the normal tissue stretch type of enfill, but it is associated with the restriction of the range of motion. The soft capsular enfill is more often seen in acute condition, with the stiffness occurring early in the range of motion and increasing until the end range of motion is reached. Then we have bone to bone infill, that is abnormal type of bone to bone infill. Normally, normal bone to bone infill, which we can get in the elbow extension motion, but in the case of abnormal infill, it is like the restrictions which occurs before the end range of motion uh, reached. So the example of the bone-to-bone landfill, it is in the cervical spine resulting from the osteophyte formation, as well as in the knee joint many times after the any replacement. If the fibrosis are getting uh, occurred around the joint, then that also cause this type of bone-to-bone landfill. Okay. Then we have empty end-filled. So empty end-filled means the end-fill is detected when the movement produces considerable pain. When we are not able to detect the actual end-fill and we are unable to go till the end range of motion just because of the pain, then we can say that is the empty end-fill. So subacromial bursitis, or in the case of tumor, this empty infill we can find. So last we have springy block type of infill. So it is mainly seen in the meniscal injuries, and there is a rebound effect with a thick stretching fill, although it is not the stretchy type. And the springy block and fill may be found with the torn meniscus of a knee when it is locked or unable to go for the full extension motion. So whenever we have these ankle joint, or the we can say mostly the knee joint injury, and if we are finding the rebound effect while checking the motion, then we can say it's a springy block type of infill. Okay, so this is all about the brief idea related to the normal infill and abnormal infill. For the further detail, you all can refer the physical assessment book, that is the MAGI. Thank you.